Hello, I'm Dr. Pratyusha. Today I'm here to discuss about an obstetric emergency, that is cord prolapse. So coming to introduction, it is one of the main causes of fresh stillbirth. It is one of the obstetric emergencies seen in maternity units in obstetrics, and timely delivery is the hallmark of good clinical management and also gives you the idea about the functioning of a unit. So in many developing countries like ours, mobilizing the theatre for emergency cesarean section may pose a challenge, and patients with cord prolapse with fully dilated cervix may have to travel long distance before reaching the center equipped for cesarean section. This usually results in fetal deaths. So what is cord prolapse? It is defined as descent of umbilical cord into the lower uterine segment, where it may lie adjacent to the presenting part or below the presenting part with or without intact fetal membranes. So the membranes are ruptured and the cord is either beside or below the presenting part. So when the membranes are intact, it is called as the cord presentation. So we have types of cord prolapse, that is the occult cord prolapse, phonic or cord presentation, and overt cord prolapse. Coming to occult cord prolapse, cord is adjacent to the presenting part in this case, where we have the presenting part and beside the presenting part we have the cord, and it cannot be palpated during pelvic examination, might lead to variable decelerations or unexplained fetal distress. Then we have the cord presentation, where the prolapse of the umbilical cord, there is the umbilical cord that is below the level of the presenting part, but the membranes are intact. So when we palpate, we can palpate the cord through the membranes, and this is a precursor where it is a harbinger of cord prolapse. Then we have the overt cord prolapse, where the umbilical cord lies below the presenting part or that is associated with rupture of membranes and displacement of cord through the vagina. The membranes are ruptured in this case, and the umbilical cord is below the presenting part, or it might also have prolapsed through the vagina into the introitus and outside. So these are the types of cord prolapse, that is the occult, the cord presentation, as well as the cord prolapse. So we have other types of cord accidents that can also lead to fetal distress and stillbirths, that is a true knot, as well as the nuchal cord. So what is happening in a true knot? There a true knot or intertwining of the segment of the umbilical cord is formed. In such cases, because if the knot is loose, the circulation is not obstructed, and it can also be delivered, the commonly found by fetus slipping through a loop of cord. We can diagnose it after delivery. Sometimes there can be variable decelerations if there is a true knot, which can be diagnosed. Then we have the nuchal cord, that is the umbilical cord is wrapped around the neck of the fetus or baby as it is being born. It is usually possible to slip the loop of the cord gently. It occurs in more than 25% of the deliveries and occurs in long cords than with the short cords. So if it is not possible to slip the cord, we can clamp the cord and cut it. So coming to cord prolapse, what is the incidence and epidemiology? The incidence of occult cord prolapse is unknown because it can be detected only by the fetal heart rate changes, which is characteristic of umbilical cord compression, that is there might be variable decelerations. But overall incidence of overt cord prolapse is 0.1 to 0.6%. Of these, it is most common in the transverse lie, where it is 20%, foot-length presentation 15%, complete breech 5%, 0.5% in frank breech, and 0.5% in cephalic presentations. So what are the risk factors? The important factor is incomplete fitting of the presenting part into the maternal pelvis at the type of rupture of membranes. So this is the most important factor that will lead to cord prolapse, where the ball valve mechanism is disturbed. The presenting part is not correctly fitting into the maternal pelvis, which is leaving some space through which a cord can prolapse. So this can be either spontaneous or iatrogenic. The spontaneous factors are fetal, placental and maternal, and iatrogenic factors are procedure related. So what are the fetal factors that cause cord prolapse? That is prematurity and IUGR, where the fetus is small or it is ill-fitting, abnormal lies like the transverse lie, oblique lie, malpresentations, fetal anomaly and multiple pregnancy, first cephalic, second transverse breech or footling presentations. In such cases, these are the fetal factors which can predispose to cord prolapse. Then we have the maternal factors, that is the rupture of membranes, which can be spontaneous or by artificial rupture of membranes, which is called amniotomy. In spontaneous rupture of membranes, what is happening is it includes a preterm as well as a term where the membranes are ruptured, and if the presenting part is high up, there can be a chance of cord prolapse. So that has to be diagnosed immediately. In artificial rupture of membranes, where we are doing for induction of labor, where the presenting part is high up, in such cases we have to do a artificial rupture of membranes in a OT setup to avoid or to take an action if there is a cord prolapse, or prior to rupture of membranes we can start on a stabilizing oxytocin drip where the presenting part is settled or fixed in the pelvis. After this, we can proceed with the rupture of membranes. Then we have pelvic tumors or cervical fibroid, contracted pelvis where the head inlet is contracted, the head is high up, so the cord can prolapse, and preterm labor. These are the maternal factors. We have placental factors, that is the polyhydramnios, where the amount of liquor is high, the cord is free, it can prolapse, and minor degree of placenta previa. So, then some authorities have also speculated that cord abnormalities such as true knots or low content of Watten's jelly and fetal hypoxia acidosis may alter the turgidity of the cord and predispose to prolapse. Now we come to the procedure related factors, that is the amniotomy, that is rupture of membranes with a high up station, external cephalic version, internal podalic version as in a case of second twin, where the second twin is in transverse lie and during the procedure there is a chance that there can be a cord prolapse. Stabilizing induction of labor, applying a fetal scalp electrode, amnio infusion and insertion of a cervical ripening balloon catheter. So these are the procedure related risk factors which can cause cord prolapse. So what is happening after cord prolapse? Why is it risky? Because once the cord is exposed to the environment, there can be an umbilical artery vasospasm due to the cold weather, which can also cause cord compression by the presenting part that is present in the inlet. That can cause cord compression, which can lead to birth asphyxia, which can as such further lead to hypoxic encephalopathy as well as the perinatal death. So this cord compression by the presenting part and umbilical artery vasospasms. So these are the main consequences or the main factors which give rise to the pathological effects of cord prolapse, which is important. So how do we diagnose that a cord prolapse has occurred? So this entity of cord prolapse should be kept in mind always, and it may occur without outward physical signs. So when should we suspect that a cord prolapse might have occurred? So during clinical examinations, when you have any abnormal fetal heart rate pattern may suggest overt or occult cord prolapse, that is the bradycardia, marked variable decelerations. Such cases we can say that there might be an occult cord prolapse. Or after the rupture of membranes, particularly if such changes occur soon after membranes rupture, either it might be spontaneous or after artificial rupture of membranes. Once the membranes have ruptured, it is definite that we have to do a vaginal examination to check if there is any cord prolapse or any fetal heart rate deceleration that is occurring after rupture of membranes. Immediate examination to be done to rule out cord prolapse. So this cord prolapse, if it is occurred, it is confirmed by vaginal examination by sudden appearance of a loop of umbilical cord at the introitus, usually after the membranes have ruptured. And we can also palpate cord during vaginal examination if the membranes are absent, and in malpresentation sometimes felt below the presenting part when the membranes are intact. So we can palpate the cord, we can feel the cord pulsations to confirm the cord presentation or prolapse. Cord presentation can also be diagnosed with ultrasound before the onset or during early labor. However, it is not sensitive or specific for identification, and it should not be routinely performed to predict cord prolapse. So how are we managing? This is an obstetric emergency cord prolapse where early delivery of the fetus is important to. So this is to prevent perinatal morbidity as well as mortality. So the various modalities of management. Our first aim is to prevent compression of the cord that is already happening and then to deliver the baby. So this aims at how are we preventing the compression of the cord. So this aims at raising the pelvis and therefore bringing the cervix to a higher level than the fundus of the uterus. So this is one important measure by which we can prevent compression of the cord, and the further management depends on the type of cord prolapse. Occult prolapse. In cases of occult prolapse, immediate vaginal examination is done to rule out cord prolapse, and the patient is asked to lie down in a left lateral position, oxygenation, discontinue oxytocin infusion if it is in place because it is causing cord compression, allow labor to progress if fetal heart returns to normal, and no further insult. Continuous electronic fetal heart monitoring is done, amnion infusion, but if the cord compression is continuing with decelerations, then cesarean section will be indicated. So this is the management of occult prolapse where the membranes are intact. Management in a cord presentation. In a case of term pregnancy with cord presentation, we can do a cesarean section prior to membranes rupture. In case of a premature pregnancy, premature infant, there is no consensus on management. Hospitalize the patient and on bed rest in a Sims position and serial ultrasound to ascertain cord position, presentation and gestational age. But whenever necessary, we can need to proceed with a cesarean section. Management of overt cord prolapse. In such cases, this is an obstetric emergency where the baby has to be delivered as early as possible. So speed is of the essence and perinatal outcome is largely dictated by the diagnosis to delivery interval. The three components of management are prevent or relieve cord compression and vasospasm, fetal assessment, and prompt delivery of the infant. So how do we prevent or relieve cord compression and vasospasm? First, manual replacement of the cord and manual elevation. That is, there should be replacement. The cord is replaced and there is elevation. We have to elevate the presenting part by the hand in the vagina. So this will elevate the presenting part up and it reduces pressure or compression on the cord. And there should be minimal handling of the loops of the cord lying out of the vagina. These loops have to be covered with a surgical pack soaked in saline, but rough handling or pulling of the cord will increase the vasospasm and reduce the blood supply to the fetus. Gently replace the cord, pack it with a warm saline and elevate the presenting part high up till we deliver the fetus. Or if it is a cesarean section, till the baby is delivered, the hand should be kept in the vagina. Or the second thing which can be done is a filling of the bladder. The bladder is filled with 500 to 600 ml of normal saline and the catheter is clamped. So this will elevate the presenting part high and relieve compression on the cord. Adjust maternal position. The position of the mother is changed from left lateral or supine to a knee chest position or the exaggerated Sims position, which is important to relieve compression on the cord. So replace the cord, fill the bladder and adjust the maternal position. Bladder filling. If the recession delivery interval is likely to be prolonged, elevation through bladder filling may be more practical because it will be difficult to keep the hand in the vagina and elevate the presenting part. But it is essential to keep in mind to empty the bladder just before any delivery attempt, either it is vaginal or C-section. So how is the bladder filling helping us? It physiologically inhibits uterine contraction. There may be contractions but not strong enough for the presenting part to compress the cord. So it helps in relieving the compression on the cord. Maternal position adjustment. So what position is favorable? We have knee chest position and exaggerated Sims. Knee chest position is feasible if the patient is in a hospital setting and the OT is nearer. In such cases, we can keep the patient in a knee chest position because it will be a short duration of time shifted to OT and deliver. But if it is for a prolonged period that she has to be transferred from the periphery to the hospital, it would be preferably a exaggerated Sims position, which is better to relieve compression. So coming to knee chest position, it gives maximum elevation of the presenting part, provides good initial evaluation of the presenting part, but it is a tiring posture to maintain. If it is for a long time, it will be better to move the patient to a Sims lateral position. Sims lateral position, it is more relaxed and dignified for the patient. Elevate the buttocks with a pillow and head down can be kept. That is a Trendelenburg position can be given. So this is the knee chest position as well as the Sims lateral position. Fetal assessment. So our further management, after we have released compression on the cord by filling the bladder and avoiding cord compression, our next assessment will be how is the fetus and what is the next management. Is the baby viable? Interventions for fetal reasons are not necessary for already dead baby, too immature to survive, or a lethal anomaly. In such cases, the fetus is not a main factor. So there is no fetal reason that we need to go for an emergency cesarean section in such cases. In these cases, allow labor to progress and deliver vaginally unless there is a contraindication to vaginal delivery. If the baby is alive, quickest way to tell is by palpating the presence or absence of pulsations in the cord. If the cord pulsations are present, we can say that the baby is alive. But if the cord pulsations are absent, the fetal cardiac activity has to be confirmed by an ultrasound. It is not completely absent of pulsations doesn't mean that the baby is dead. It has to be confirmed by an ultrasound. Beware of mistaking fold of membranes or tip of fetal fingers and toes for cord. Absent pulsations should be confirmed between contractions in case of cord compressions release and pulsations return. So that should be done between the contractions. Fetal heart auscultation best determines whether or not the fetus is alive. Electronic fetal heart monitoring is useful, but if the real-time ultrasound is confirmatory. So before we proceed with delivery of a C-section, it would be better to document the fetal heart by a ultrasound scan so that we can prevent unnecessary sections if the fetus is dead. Prompt delivery. If the cervix is fully dilated, the vaginal birth can be attempted at full dilatation if it is anticipated, and delivery can be accomplished within 20 minutes from diagnosis. So once the cord prolapse has occurred, within 20 minutes, if the cervix is fully dilated, the station is low down at +2 or +3. If we can immediately deliver the baby, we can proceed with a vaginal delivery. It can also involve delivery by forceps, vacuum, or a breech extraction. So breech extraction, that is after IPV for second twin for singleton breech babies with the presenting part distending the perineum. So in such cases, if we are able to deliver the baby immediately, within 20 minutes we can proceed with the vaginal delivery. If the cervix is not fully dilated, then the main route will be a immediate cesarean section within 30 minutes or as early as possible to prevent hypoxia. The 30-minute decision to delivery interval is the target for cesarean section. Some investigators have noted that the interval to delivery had little effect if the Apgar scores if they delivered within 30 minutes. So that is a very urgent cesarean section, which is an obstetric emergency. So prompt delivery. The presenting part should be elevated during induction of anesthesia and placement of sterile sheets. All this time, the presenting part should be kept elevated either with a full bladder or with a hand in the vagina or with a Trendelenburg position also. But if the bladder is full, we have to remember to drain the bladder before incision. Recheck the fetal heart or confirm it with the ultrasound before incision. Regional anesthesia or general anesthesia can be given. A practitioner competent in the resuscitation of the newborn, a neonatologist should attend all deliveries with cord prolapse. Neonates born after cord prolapse are at significant risk of, they are at need of resuscitation because of the low Apgar rates and increased risk of acidosis. So a neonatologist should always be available at the delivery table. So this will occur in a hospital setting. So what is the difference between a community setting and a hospital setting? In a community setting, transport of the mother and the communication to the health services is delayed. So there is an increase in perinatal mortality in cases of cord prolapse occurring outside the hospital, even compared with an unmonitored fetus who had cord prolapse while in the hospital. So women should be advised over the telephone to assume knee chest or Trendelenburg position while waiting for hospital transfer. But during ambulance transfer, because the knee chest position is difficult to maintain, the left lateral or the Sims position should be used. All women with cord prolapse should be advised to be transferred to the nearest consultant unit unless an immediate vaginal examination reveals that spontaneous vaginal delivery is imminent. Preparation should still be made. So during the time of the transfer, the presenting part should be kept elevated with a Foley's catheter. Prevention. So how can we prevent cord prolapse? Women with transverse, oblique or unstable lie should be offered elective admission at 37 weeks or sooner if there are signs of labor or ruptured membranes. Women with non-cephalic presentations and preterm pre-labor rupture of membranes should be offered admission. And inpatient care will minimize delay in diagnosis and management of cord prolapse. Labor or ruptured membranes of an abnormal lie is an indication for cesarean section. So bradycardia or variable fetal heart rate decelerations have been associated with cord prolapse and their presence should prompt vaginal examination. Whenever we find bradycardia or variable decelerations on a CTG, proceed with a vaginal examination to see if there is any cord prolapse. Mismanagement of abnormal fetal heart rate patterns is the commonest feature of substandard care identified in perinatal death associated with cord prolapse. Speculum or digital vaginal examination should be performed when cord prolapse is suspected regardless of the gestational age. So, for the diagnosis, prompt vaginal examination is the most important aspect of diagnosis. Artificial rupture of membrane should be avoided whenever possible if the presenting part is unengaged or mobile. If it becomes necessary to rupture the membranes, they should be performed in theatre with capability for immediate cesarean birth. And vaginal examination and obstetric interventions in the context of ruptured membranes carry a risk of upward displacement of the presenting part and cord prolapse. Rupture of membrane should be avoided if on vaginal examination the cord is felt below the presenting part, that is cord presentation. In such cases, a cesarean section should be performed. Counseling. Postnatal debriefing should be offered to every woman with cord prolapse. After severe obstetric emergencies, women might be psychologically affected, and postnatal depression, post-traumatic stress disorder, or fear of further childbirth. So they need to undergo urgent transfers to hospital and are particularly vulnerable to psychological trauma. Debriefing is an important part of maternity care and should be offered by a suitably trained professional. By conclusion, cord prolapse is a frightening and life-threatening event that occurs in labor. Rapid identification and immediate appropriate response may well save the life of a neonate. Therefore, clinicians should be knowledgeable in recognition and management of cord prolapse. Thank you.